Bridget has her PhD in Health and Behavioral Sciences from the University of Colorado, as well as an MPH. She is currently a Senior Program Officer for PCORI in Communication and Dissemination Research. And prior to that, Dr. Gaglio was a research scientist at Mid-Atlantic Kaiser Permanente, as well as a center manager for the Center for Health Dissemination and Implementation Research at Kaiser Permanente, Colorado. So I think it would be very hard to argue that Bridget is one of the country's current experts in dissemination and implementation research. She is prolific in her publication history in both peer-reviewed journal articles and has 2 book chapters on the topic. So I think that we're all really excited to have the opportunity to hear Bridget talk about something that she knows so well, which is applying RE-AIM to stakeholder engagement. So with that, I will hand it over to Dr. Gaglio. Bridget, are you there? Bridget, if you're there, we are having a hard time hearing you.
Renee?
Yes, okay. Yeah, now we're hearing you. Okay, if you want to take it away, Bridget.
Okay, thank you, and thank you so much for the very, very kind introduction, Renee. That was very sweet of you. Yeah, so today I am going to do a brief presentation on applying RE-AIM to patient and stakeholder engagement. I really would like to leave as much time as possible for us to have a really good discussion and conversation around this. So with that, for today's talk, I'm hoping to cover 4 things in the short amount of time that I'm going to chat. One, I will just do a really quick RE-AIM review, because I know there's probably a few people who are joining today's session that have not used RE-AIM or might not be as familiar with it as some of the others on the phone. So I'll cover that rather quickly. Then I would like to provide a definition on what engagement is. I will also share with you the engagement rubric that PCORI has created just to kind of help people think about how engagement can be incorporated in the research process. And then the last piece, which I think will be the most interesting piece, is applying RE-AIM to this engagement process. And I will be very honest in that this is the first time, once I got volunteered from Borsica to do this talk, it's really the first time that I've sat down and really thought about how RE-AIM could be applied to engagement. So I really look forward to the conversation afterwards to see if people are in agreement or if you think I'm really way off base on this. So with that, I will move on. So RE-AIM. RE-AIM is a framework that was created quite some time ago now. I guess I could make fun of how old it is because Russ isn't on the call today, but I won't. But it's an acronym, and it stands for 5 dimensions that hopefully, when evaluated over the course of a project, will be able to help enhance the quality and the speed and hopefully the public health impact of research to translate that into practice. And so when the framework was originally created, it was really focused on evaluating projects after they were done. But since that time, it's now used for planning, looking at the actual conduction of the research. We've done systematic reviews with it, and then now the newest iteration will be today in applying it to engagement in research. So very quickly, For those who are not familiar, REACH is the absolute number and proportion of individuals who are willing to participate in your intervention or program, whatever it is. And so we're really trying to look at the representativeness of those participants. So looking at who are you trying to target, who's eligible, and out of all of those folks, who actually participates, and do they look like the bigger population at large. We are looking at this at an individual level. And the quick way that I always use to remember REACH is that it's focusing on who. Who do you want to participate and who ends up participating? So then the second domain for this framework is effectiveness. And so we're looking at how well the intervention affects change, so in your primary outcome of interest. And so when the framework originally was created, this was the main component of looking at effectiveness. And over time, it's really evolved to incorporate looking at quality of life, looking at unintended consequences from the research. And so that's one thing I think that has allowed REAIM to be used in as many different ways that it's been used, but also to stand the test of time so far, is that it has continued to evolve since the original inception of it, and it's only just made the framework stronger for us to use when it comes to looking at the research. Also effectiveness, so you're looking at your primary outcome of interest. This can be done in the interim, short-term, and long-term. And then, again, this is also looking at being measured at the individual level. And for kind of thinking about effectiveness and remembering what it is, it's focused on the what. What about the study are you looking at? And so that's where this dimension focuses. So then we have adoption. So adoption is similar to REACH in that we're really interested in representativeness, but here we're looking at representativeness of the settings in which the research is conducted and also the staff or the intervention agents that are going to be delivering that intervention for you. And so again, you're going to look at the number of settings that are eligible to participate in your project, and then look at how many actually do participate and are they representative of the larger sample. And then the same assessment would go for your staff or intervention folks who are going to be delivering that intervention for you. One thing I really want to highlight for the new folks for adoption is this is really focused on the where, the environment in which the intervention is going to be conducted. A lot of folks get REACH and adoption confused, and so always remember that REACH is focused on who and adoption is focused on where, and you won't go wrong. But we have seen several instances where people will get those flipped, and it's not the right use of the framework. So then implementation is looking at the extent to which the intervention is delivered as intended. And not only is it just overall, but if you have a multi-site project, you're going to want to look at consistency across those different settings and how the intervention was delivered. And then if you have multiple staff delivering the intervention, you're going to want to look to see if there's any variability in how those intervention agents delivered the intervention over time. And so to remember what implementation is representing is looking at the how of the project. How did it unfold after it went live in the field? And then last is maintenance. And so maintenance is measured at both the individual and the setting level. And so at the individual level, we're looking at how long were effects of the intervention sustained over time, or were they sustained over time? We're looking at participation over time and looking at if there was, the short-term versus the long-term attrition, and did that vary across either the intervention arms, particular groups of participants, things of that nature. And then the setting level, we're looking at the extent to which the intervention is sustained or over time, and if it was modified or adapted so that it could be sustained after the study ran its course. And so for the maintenance piece, we're really focused on the how long. Once you've introduced this intervention, how long does it work for the individuals and how long is it staying in the setting in which you delivered it? Okay, so now that we're done with the quick re-aim primer, we're going to talk a little bit about engagement, and then we'll move on to putting this all together. So I wanted to provide two definitions here because we hear patient-centeredness and patient engagement used a lot, or at least I do, and that might just be because of the environment in which I operate on a day-to-day basis. But I feel like these terms are becoming more mainstream, and some folks might not know what they mean, and so I just wanted to be mindful of that and provided at least the definitions so you knew where my frame of reference was for this talk. And so when we talk about patient-centeredness, we're really looking at to see, do the questions and the outcomes of the project matter to patients and caregivers? So at the end of the day, is this really focused on something that is important to the people it's intended to help when the project's over? Patient engagement, on the other hand, is really partnering with patients and caregivers and stakeholders. So these folks are going to be actively engaged and integrated into the research team in some capacity, and that varies. Some folks have advisory boards of a set of stakeholders brought together that they consult throughout the course of a project. Others have a patient or caregiver or stakeholder as a co-investigator on a project, and everything in between. But it really is having these folks be actively involved as part of the research team and not as a research subject. And so that's where the difference is with these two, what I really wanted to highlight between the differences. So here is a visual of the engagement rubric that PCORI has put together. Similar to re-aim, where re-aim can be used to help you plan the study to identify who you're going to outreach to, who you want to target for the intervention, what your outcomes are going to be, and then being able to use those same criteria to evaluate the study as it's running its course, and then also looking at the evaluation piece. We expect to see engagement in these same pieces of the study. So for planning, we really would like to see patients and stakeholders involved in identifying what the research questions are, identifying what the comparators are, what choices are these folks going to have in the real world, and are they instead of creating something that doesn't really exist in an artificial environment, make those comparators very relevant to these folks. Have them assist in helping identify what the outcomes are, because at the end of the day, they're the ones who are going to be using this information, hopefully, to make an informed choice. And then we'd like to see them involved in conducting the study. And so again, this is where you would have either your advisory boards that you would continually engage with while the study is playing out, sharing interim results with them, presenting how the recruitment's going to them, if there's issues, kind of brainstorming new ideas for how you might overcome those challenges, things of that nature. And then at the end of the study, hopefully if you've had great engagement in the planning phase and conducting the study, these folks will have provided you with the information so that you have results that are meaningful and useful to your end users, and then these individuals can hopefully help identify what channels and mechanisms to best disseminate those findings to reach the largest amount of individuals. And then the PCORI engagement principles are, we're focused on creating reciprocal relationships. So the scientist is the expert in the science, and the patients and the caregivers are the experts in the patient experience. And so really creating a relationship that supports give and take from both sides, that not only you learn from each other, so there's co-learning going on, but there's also this partnership that's being built to move the science forward to help the patients. And then again, looking to create an engaged relationship that has trust and transparency and honesty. So that's the engagement rubric, and I'm happy to chat more about that offline if folks, we could talk about it today, but also I'm always available offline to talk about how this would be incorporated into an application. So putting it all together, so applying REAIM to patient and stakeholder engagement. And again, this is hot off of the press, like seriously, so I take no offense if you have criticisms afterwards. So reach and engagement. So your project, how do I reach the targeted population with the intervention you're coming up with? So as I said earlier, you really want to engage people that represent your population of interest and other stakeholders as appropriate. We'll talk a little bit about that more in adoption for sure. But we really want to pull people from that community, whatever that population is that you're interested in focusing your research on, bring them to the table early on because one, they can help you identify what's important to that population. They can help you identify who really should be the focus of that work. So looking at some inclusion, exclusion criteria, particular demographics, et cetera, they can help you figure out your recruitment strategy because they're familiar with that population because they come from that population. And so having engagement during the planning phase of the study can really have a positive impact on the reach of your work. And then similar for effectiveness, how do I know my intervention is effective? And when I was thinking about this question, I thought, okay, well, yes, we always want our primary outcome to be significant in a good way because, that's what's going to get our papers published, that's adding to the science. But at the end of the day, is your intervention effective? Do we really step back and say, well, do I consider my intervention effective if people use the information, if people can access the information, if the information is meaningful to them? And so I think that's another level of effectiveness that we can evaluate our science on. And so again, a lot can be done in the planning phase that can help this question be answered as yes. And so bringing folks to the table to, again, help develop the research questions, identifying the best comparators for that project, and then, again, selecting outcomes that really are meaningful and that will allow someone to make an informed decision relevant to the topic being studied. So for adoption, how do I develop organizational support to deliver my intervention? So it probably doesn't sound like a repeat of REACH, but you really need to engage the folks at the setting level. So if you're going into clinic, which, I have worked on several projects in the past where we've developed these great interventions and then gone to solicit the environment to participate. So go out to clinics, go out to settings and ask them to deliver the intervention. And once we're there to say, okay, we need a nurse or someone here to actually deliver it, and these folks never had a say in the design of the project and what would, to let us know what would work best for them in their setting. And so having these folks engaged in the beginning allows you to understand the environment in which you're trying to intervene on. You're also going to get a better sense of who might be the best intervention agent in that environment. And so by taking all of this experience and contextual knowledge from these folks at the beginning, we'll hopefully be able to allow you to develop an intervention that would really just nicely fit and integrate into the settings, so that once the study funding is over and is done, that it's already just nicely fit in and can continue to be available and in use once the project, the research portion of the project is over. And then again, similar to REACH, if you're engaging these settings and the intervention agents early on, they can help you figure out what might be the best environments and the best people to include in the research once it's really gone live. So then for implementation, looking at how do I ensure the intervention is delivered properly. And so here's where I really struggled at first, because of course, we're looking at implementation from, what resources were needed to deliver the intervention as envisioned, or, what variations occurred and why did those variations occur. But then I started thinking, okay, well, if I have an engaged group of folks, either as an advisory panel or part of my research team, I'm definitely going to be engaging them in those conversations around how the study is being conducted and, any changes that might have occurred during the implementation phase. But then I also thought, well, understanding how engagement played out would also be important. And so, you've put this layer of engagement over the research process, and we're trying to understand the research process. But really, how did the engagement play out, and how did that impact the research project? So I thought that was really something new and something that would really be important for us to look at. And, having patient and stakeholder engagement is time-consuming because that's another piece of the project you have to continually include and folks you have to work with. So it can be resource intensive in terms of time and funding, because most of the time these folks who are giving their time to your study are compensated and paid in some capacity, and so there are these additional resource constraints on the project when you bring a strong engagement piece in. And so kind of looking at what that impact had, but then also the overall, impact on the implementation of the project itself. So I thought that was something I definitely would like to hear people's feedback on. And then last is maintenance. How do I incorporate the intervention so that it's delivered over the long term? And so again, I thought, all right, we're going to look at, hopefully, if you've done a nice, thorough job of engaging patients and stakeholders in the early stages of the planning phases of the study, and in looking at REACH and the implementation and all of this coming together, the individual and setting level maintenance, hopefully we would see positive outcomes in that regard, and that we might hopefully see longer-term use. Whatever outcome our primary outcome was, hopefully see long-term effects in the individual level, and again, sustainability at the setting level and with the intervention agents. But then I thought, well, this is another opportunity to put the engagement piece on top of that, and thinking that engagement could be looked at 2 levels for maintenance. So we have the sustainment of relationships, and I was thinking, well, we have the sustainment or the relationship building more at the individual level among the scientist and the patient stakeholders, and so looking at the sustainment of that relationship in and of itself after the study's over, but then also looking at the engagement of our patients and stakeholders with the intervention itself, because hopefully if they're coming from community and they've been involved in the development and the design and what's actually being implemented, they're really bought into this. And so looking at how they engage or continue to engage and keep that relationship going with the actual intervention after the science piece of the study has been completed, I thought would be of interest as well. So with that, just some parting points, and then we'll open it up for discussion. So again, REAIM's been used to help us do a better job of understanding our research and hopefully being able to translate research into practice, especially in the real-world setting. And having engagement in the research is necessary for understanding what that real-world setting is. And so they really are, they go hand in hand. And so like planning a research project, engagement requires planning as well, and it really needs to be thought out, and it needs to be incorporated in all of the pieces of the project. So with that, I just thought both, REAIM and engagement are designed to enhance quality, impact, and speed of efforts to translate research into practice. And so I hope that with this short presentation, I've made that case. But I'm always up for the challenge to hear otherwise. And so with that, I will turn the floor over to Marcia, and we'll open it for the discussion piece of the meeting. Thank you.
Thank you. Thank you very much, Bridget. What we've decided to do is to sort of have the moderator, Renee, and then I'm going to be the first reactor, and then we're truly going to open it to the whole audience. So on behalf of the whole audience, Bridget, I'd really like to thank you for your excellent presentation. You sort of introduced this as first thoughts, but your first thoughts about linking REAIM and engagement, I think, and particularly around the research implementation aspects, have been really thoughtful. What I'm so pleased to see is REAIM concepts incorporated into major federal agencies. And these are agencies that have direct implications for the design, the conduct of research studies that can really make a difference. I see what you've talked about as a perfect example of the transition from theory to research to practice to policy. And it's something that Russ and the others could only dream about 2 decades ago, about how something that was theoretical is really being applied both in real-world settings and to engage more research around real-world issues. So several funding agencies, other ones besides PCORI, have adopted REAIM constructs. I know the CDC has, the Administration for Community Living, and probably many others. But I think what you point out is the unique aspects around community and stakeholder engagement. So I have 2 questions or comments to start the conversation. One is more theoretical, research-oriented, and then there's a practical one related to how one can enhance funding success at PCORI and other institutes that are requesting more community engagement. So let me just sort of name both of them. First, and we're thinking about the REAIM part, how can we get folks to focus more on organizational aspects? And this is not just individual outcomes, but it's in terms of looking at organizational practice change. And then if we are focusing on organizational practice, what methodologies might be used? I know for some of our community work, we've been looking at social network analyses, and this has helped us better understand the structure and relational processes of different partnerships. So that's a question that I would like to ask. What kind of methodologies are people using as they think about more organizational outcomes? And secondly, I think we all agree, everybody who's sort of tuned into your talk, Bridget, agrees about the importance of community and stakeholder engagement. But to enhance one's success for PCORI funding, and now I'm speaking as a potential investigator, how much do investigators need to do on the front end to describe patient and stakeholder engagement? And then for the open discussion, I'd like Bridget to address, or others, some good examples of well-formulated plans, because one of the things you said is either have done this and document it or have some well-formulated plans. So with that, I just want to, again, Bridget, thank you so much, and hopefully these two questions about organizational aspects and how we can sort of quantify and describe the engagement process and what we need to do for grants. So let me end, and I guess we're back to Renee as moderator.
Okay, I think that was a terrific summary, Marcia, and I fully support all of your comments and appreciate and want to thank Bridget for a very provocative talk introducing some of these new thoughts today. So given what Marcia has said and shared with us, I'm just hoping someone would like to jump in here, and perhaps, Bridget, I should give you the first opportunity to react to what Marcia said, and then we'll open it up to further questions.
Okay, so for the first piece about the question about, looking at organizational practice change and not just individual outcomes, getting more folks to focus on that, I think that's a great question. And when I heard you say it, I was trying to think, it's like, well, first of all, I know people probably shy away from it because, one, it is very hard to do. Not very many people have had success at it lately. But the other thing I was wondering, which might also kind of serve as a barrier to really taking on that challenge, is the priority. I think about the funding process and how long it takes, and if you're meeting with the folks at the organization who are key to making large change or any change, you meet with them, you talk to them about your research, and they're on board. It's aligning with the priorities of the organization at the time you write your application, and then you submit it, and then there's this long lag time with the review process, maybe a resubmission, things of that nature. And so I'm wondering if then by the time the application's actually funded, the priorities of the organization have probably changed, and this area might not be the focus anymore. And so having to go up against what's no longer a priority might just make the environment harder to change in and of itself. But that was just my initial reaction to that question.
Yeah, and this is Renee. I'll jump in again. I think that's a really excellent point, Bridget. And I can speak for some of my own research and bringing community partners on board, that the grant and funding process is just so lengthy that by the time the funding is by the time the funding is received, the concerns of the organization or what they're offering. For instance, if we're talking about health promotion interventions, they may have very well decided, well, I don't want to sit around and wait 12 to 18 months for your work to be funded. I'm going to move on and look elsewhere and perhaps bring on another program. So I think that is a real challenge, for us researchers in keeping community partners engaged.
This is Marcia. I think it's a challenge, but I think it's something, if we really want to talk about sustaining change, so if we have interventions and our goal is to sustain them over time, I think the only way we're going to sustain them is to get this organization community buy-in. And if that's sort of a goal, then from a research perspective, how do we measure that? And maybe that's part of the question too. And I think the difficulty is, you're right, it's such a long process. Priorities may have changed, but it's also very difficult, I think, to measure the organizational outcomes. They're not quite as clean, but people are starting to do it, but I don't think they're quite as clean as individual behavior change.
So what questions do others have? Please step in if you have a question for Bridget.
Well, while we're waiting, Renee, I can go ahead and, if you want, I can address the second question that Marcia had about kind of what does engagement look like for a potential investigator, like how much needs to be done on the front end, if that's what I remember the question being.
Yes, yeah.
So we actually expect quite a bit. So we do expect so here we have a two-stage process, so you have to submit a letter of intent and then the full application if you're invited. And during the letter of intent phase, we really want to see at minimum that patients and stakeholders have, one, been identified, and two, have really had a say in this early phase of the process. So when you are submitting an LOI, you've kind of got your idea, you know what the aims and the research questions are and what the outcomes are going to be. And so we really would like to see, you know, in the LOI you don't have a lot of space to demonstrate the involvement, but, you know, in a paragraph you can state that you've already put together an advisory board, or that you've had so many patients and stakeholders weigh in on the research questions or the outcomes, however, and then in the full application phase, part of the process, there's actually an engagement plan required in the application, and that allows you a lot more space to say what's been done to date in terms of engagement, and then what that plan will be to continue engagement throughout the entire research process. One of the things that I can really say, if you do get invited to the full application process, is the letters of support are really looked at, and they're really called out when all of them are carbon copies of the other one. They really, the reviewers really take issue with that and really question the level of engagement of the folks who have written these letters, because they all say the exact same thing. And so having really genuine letters of support for your application definitely go a long way. And it looks like,
questions for Bridget?
Sarah. I thought Sarah Madrid, did you raise your hand?
I did, yeah. Hey, Bridget.
Hi, Sarah.
How are you? Great presentation. Thank you so much, and it's just been really fun to see all these names of people on the list of participants today who are old friends and colleagues. I would like to ask you to expand a little bit on the I and the M, because I'm working with a group from the HMRN to look at how to assess impact of engagement. And I'm kind of intrigued by the possibilities of the implementation and the maintenance pieces. And I'm just wondering if you could go into a little bit more detail about how you think that could be used to assess how patient engagement impacts not just the players, but and the research itself, but maybe some other long-term outcomes or interim, medium-term outcomes that we haven't really thought of yet. I'd just love to hear what you have to say about that. Thank you.
Oh, this is where my initial thoughts are going to run short on me. That's a good question, Sarah. And I definitely would love to hear others' thoughts as well. You know, so when I was originally thinking of this, you know, you go into a study with, you know, your grand idea of how things should be and are going to be. And so I think, you know, from an implementation stance, you know, we could do with engagement what we do with the research is, so, okay, we look at what we thought was going to happen, and either mid-course or somewhere along the way, we can do a self-evaluation as to, you know, is our engagement going the way we originally thought it was? And if not, what's the variation? Why did this variation occur? Is it a good thing? Is it not a good thing? Do we need to change anything? And then at the end of the study, kind of doing that same assessment to say, you know, this is what it ended up being. And do we think it was a good thing or not? In terms of, you know, longer term maintenance, that's a really great question, because part of it, I think, isn't, you know, some of it is, or I guess I get held up with the fact that, you know, the research dollars only go so far. And so maybe the HMRN setting is a good setting in that, you know, even though a study might be over, you still have this group of folks together in terms of science, but also would have access to patients to be able to do a longer-term assessment. But I think it would go back to maintenance in that, you know, were the individual outcomes and the setting level outcomes maintained to whatever point it is that you're looking at, and you want to look at why. Why were they maintained? And hopefully, if the engagement was good and had a strong impact, that would present itself as one of the reasons why. But that's just kind of thinking about it right here, right now. I don't know. What are your thoughts, Sarah?
Oh, way to turn it back. Yeah, we're having a heck of a time. We've been doing a lot of digging into the current literature on evaluating impact and engagement, and honestly, there's not a ton out there. And so I think we've been looking a lot at sort of defining early on what your outcomes are that you want, and of course this goes to your point of planning ahead of time really carefully what it is that you want to achieve with your engagement in the context of the particular study that you're doing. And so I think for the purposes of the workshop that we're holding next month, I think we're really going to present what frameworks currently exist and then start talking about how to identify which framework is most applicable to your context, and then sort of take it from there. We don't have a ton of time during this workshop, but I think we are going to try to have a meeting here in Denver in October to look specifically at how to assess impact. And we'd love to have your participation or anyone else who's interested.
Oh, thank you. That sounds very interesting. I look forward to seeing what you guys come up with.
Yay. Thanks, Britt.
Oh, my pleasure.
Other questions?
This is Diane. Can you hear me?
Yep. Hi, Diane.
Hi. Nice presentation. This whole topic of engagement is really, it really hits home to a lot of the work we've been trying to do. And we tend to talk about champions and using champions to try and implement change within a setting. And what I'm starting to figure out is the level of the champion and sort of the political will that they have and ability to allocate resources makes a difference. And I'm curious if other, you know, what I'm starting to think about is how do you sort of assess for that before you work with an organization to make sure that the people who are championing it actually have enough power to work with you and help overcome the obstacles, because there's so many when you're trying to, as we all know, when we're trying to implement things in the setting level. You know, is there a way to assess for the political will of an organization? What are all their demands, and who do they need to get on board to make something happen? You know, how much power do they have to sort of lead something? we've been shut down with some of these even when the chief executive is totally on board, and then there's someone else, you know, who's maybe a director of, you know, their chief of medicine who shuts it down, and they can't just get past that obstacle. So it's not really a question maybe, but just something that, you know, I'd love to hear from others if there's a set of measures or pre-assessments we should be doing to make sure that we're not setting people up to fail. Any thoughts? Or, you know, and I could see that as part of an engagement plan. It's almost like, how much does this really matter to the people involved in the organization, and how does that change, you know, over time? Like, how do we keep people motivated?
Diane, this is Marcia. I'll sort of jump in, and I bet Bridget will have some thoughts too. This reminds me of some concepts about organizational readiness. In a way, we're talking about champions, but you know, how do you know, and what are the characteristics of organizations that are ready to work with you? So whether it's organizations or champions. And so, you know, there are all of these principles like you should have the same, you know, should be within the organizational fit and mission. But I think you're right. You can have this set of principles, and then it will look good on paper. It looks great on the front end of an application, and 6 months later, there's a change in leadership or a change in priority, and what you thought was a common goal no longer exists. So I don't think we can ever be assured, but I think there are certain things like making sure the missions fit, that there's appropriate infrastructure, that you're not asking people things that they're not going to have resources to do. But maybe others know, I mean, there are those organizational readiness tools, but maybe others have some other ideas too, but this is a really great issue to think about.
Yeah, no, I agree with Marcia, Diane. It is definitely, it's challenging to say the least, but I think that is definitely probably the area of literature to start with for the assessments. And then, you know, the area that we work in, you know, health, it's so complicated in and of itself because there are so many players, and trying to identify who that real key individual is could take the entire course of a 5-year project in and of itself. And so, yeah, I don't think there's a real easy answer, unfortunately, at this time, but I would definitely agree with Marcia about maybe the organizational literature.
Well,
yeah,
and Paul, I was going to say, you know, I think even from you know, if you kind of go to community-based participatory research literature, and I know, Diane, you're very familiar with that, but you think of community participatory planning and evaluation, and, you know, one of the key things within that type of process is that you're identifying early on, which I think really fits nicely with PCORI model of project support, but identifying early on, you know, who are the stakeholders that are there, where are the places that we might run into roadblocks, and if there is going to be a stumbling block, try and move it up as close to the beginning of the project as you possibly can so that you're addressing it earlier. But it makes me feel like, you know, from that literature, there's some different tools related to developing the process, not as much, I would say, about a measurement tool that would be able to predict for you if the thing was going to fall apart, you know, 3 years down the road.
Yeah, thank you all. And, you know, one thing that we did find was that when we were able to identify something that was very meaningful to them, such as some sort of report that they could get and put up on their, you know, report to the people they lead to, how they're addressing an issue that was of very high importance to them, that, you know, they're a way to systematically collect some key measures that they could do themselves and track and set some performance standards for their teams that would be measurable. Those sorts of things seem to help sustain engagement with at least one of the organizations we worked with who's really, was a success story. But that was them, so I'm not sure how much that would, what those things would generalize to other settings. I guess it would have to be sort of setting by setting, figure out, what would it take for them to remain engaged and keep the whole organization going after the, even during the research and then after the research. Just a few thoughts.
Yeah, I think that we really walked into an area that I think there just is so many research opportunities, and it's so impactful on communities as well. And the more and more people start talking about things like collective impact and trying to embed a little bit more structure to when we're trying to do these types of broad systemic things across multiple organizations, and trying to come up with a way that there is infrastructure type of support. And that's kind of what I liked about, well, there was a lot of things I liked about Bridget's talk, and thank you, Dr. Gaglio, for your talk. It was great. But this idea that really there is engagement in and around REAIM outcomes, and that in some ways, really what we're talking about is that that engagement is part of the infrastructure, and starting to build an infrastructure that may be related to a specific study at hand, but in fact is more related to an overarching mission for improving the health of a community. And so then it allows for a little bit more flexibility. If one project doesn't move forward in the way they wanted it to, hopefully there's another direction that can go to keep moving that way. And so I'm hopeful that we're going to come up with more measures that help us to understand how we get these collectives of community organizations together and then sustain that infrastructure that allows us to answer multiple questions over time.
We just have a few minutes left. Is there one more question before we wrap up?
Okay, I'll throw one more in there. Bridget, this is kind of related to some of the earlier stuff. I'm really curious with the PCORI funding structure, starting with the letter of intent and then getting the full proposal. My first part of my question is, do people get funded at a quicker rate than with an NIH type of proposal? And the second part of that question is, do you guys track the degree to which things are sustained beyond the life of the research?
Oh, good questions, Paul. So in terms of if we fund quicker than NIH, I think the length of time is roughly the same, because we do have the letter of intent, and then it goes to full application, and then we have our review process. So I think it's about a year start to finish, if I'm not mistaken, or roughly about a year for funding. I could look at a timeline and actually get you a more definitive answer, but I'm thinking just through all the processes, it's about a year. And then in terms of evaluating the sustainability after a project is over, that is a fantastic question, which we do not have an answer for right now, because our first awards are just now coming to where they're going to end here in the next several months. And so we don't have any long-term data to look at as of right now. We will hopefully be looking at that as these projects come offline, but we are just in the very, very preliminary phase of the projects coming to completion.
Thanks, Bridget.
Mm-hmm.
Okay, with that, we should probably wrap up the call. We're about at the end of the hour, so thank you so much, Dr. Bridget Gaglio for the wonderful presentation. I think our entire audience would agree that it was that you've really presented some unique and interesting thoughts today that we'll all be thinking about beyond the length of this call. So thank you all, and Samantha or Paul, is that a close, or do you guys want to wrap it up?
That is great. Thank you, Dr. Smith-Ray. Outstanding job moderating today. And thanks too for the respondent, and to Bridget for a great talk. And thanks to everybody who showed up. I think this might be a record for participation.
Yes, and join us on the third Tuesday of May for our next reading webinar.
Great.
Okay,
well, thanks,
terrific.
everyone.
Thank you all. Thank you, Marcia.
Thanks, Bridget.
Bye. Thank you.
Thanks, Bridget.
Thanks.
Okay.